Hello, my name's Stella Dilk. I'm a research fellow here at St Mark's Hospital. Thank you very much for the opportunity to present my work. Today I'll be talking about the defunctioned gut. I have no conflict of interest. My work was sponsored by Bowel Research UK and supported by the Leonard Jones Intestinal Rehabilitation Unit here at St Mark's Hospital. I'd like to start first by asking you to consider the impact of bowel homeostasis and what a delicate and complicated process it is. In order for the bowel to appropriately digest and absorb nutrition, you need to have a functional microbiome and metabolome, bacteria to break down resistant starches into short-chain fatty acids to provide fuel for colonocytes. You need a bowel wall with appropriate integrity and thick enough mucus to prevent pathogens from getting through, but also to enable appropriate absorption and moderation of intestinal content. You need an immune response that is finely tuned enough to pick up on abject threats, but not so over the top that it attacks everything coming into the lumen. And you need gut hormonal profiles determining the speed at which luminal transit happens. Now, aside from the initial pathologies which have brought the patient to the operating table, and many of these have an impact on the microbiome, the metabolome, and the immune response, doing an operation itself has a direct impact on this delicate homeostasis. And John Alverdi of the University of Chicago coined this the pathobiome, the promiscuous use of antibiotics, operative stress, and the inflammatory response combined to create a response which is wholly abnormal and in which every single piece of this homeostasis is affected. Now consider again the impact of formation of a defunctioning ileostomy, where you have an intentionally disrupted luminal flow, an intentionally disrupted microbiome and metabolome because the luminal flow is not there, and potentially an adjustment in the immune response and bowel wall integrity as well, and what the long-term implications and short-term implications of this are. Now, this is an intestinal failure conference. Many of us know that the implications of having an ileostomy may be high output, but why would this be the case? Now, if we consider the endocrine feedback loops that govern how the bowel works, they are centered around an ileal break from the small intestine, a colonic break from the large intestine, and this presupposed sigmoid colonic break, which I will not talk about today. And essentially, they are coupled by a G protein coupled receptor. Luminal transit passes through, and colonocytes start producing either GLP-1 or PYY, depending on where they are in the gut. These feed back more proximally in the gut and slow down transit to allow for maximal absorption. And Breton et al. In 2016 linked this beautifully with the byproducts of E. coli, so the metabolites that E. coli species were producing, suggesting that they were able to, with their byproducts, upregulate levels of PYY and GLP-1, thereby linking this homeostasis together: hormones, microbes, colonocytes. So, bearing in mind the impact of a defunctioning on both the ileal break and on the microbial communities that reside in the gut, what would be a way of ameliorating this effect so that we could try and reduce either high stoma output or fewer long-term implications? And an answer to consider is distal feeding. So distal feeding has been used fairly widely across the world for the treatment of intestinal failure, and it involves intubating either the ileum or the colon with a tube and directly feeding into the defunctioned segment, as you can see in the picture on the left. And there's a bit of variability across the world with the choice of diet. I'll show you in a later slide how we at St Mark's distally feed, but I'll talk through for now the results of a systematic review on the subject. So if we look at all of the papers investigating the impact of distal feeding, all of the papers use either small bowel effluent reinfusion, a prebiotic infusion, or a mixture of the two, consistently across the world. However, the feeding duration, which varies between a day and 2 months, and the mode, whether it's bolus or continuous, are highly variable. None of these results were amenable to meta-analysis because they were so heterogeneous, but they showed that distal feeding reduced the use of PN, reduced proximal stoma output, and reduced post-operative complications including ileus, and that the results were most favourable in proximal fistulae. And at St Mark's Hospital, we use two methods of distal feeding. We distally feed with a prebiotic mixture, which is a bolus feed twice a day, and then we also distally feed with chyme, although there are exciting new products that have been made available, which we've started to hopefully use more in terms of reinfusion. And I'd like to show you a video of one of our distally fed patients explaining the process of his reinfusion with a prebiotic.
Now I'm ready to change my bag. Dry cloth. First clean all the muck away. Then I use a wet one. Then I use dried. Now I'm going to be ready for a feed. Glove on. Load the syringe up. Another syringe with water. Dip my little finger in the water. Then I put the feed tube in. Sometimes it's a little bit tight going in. You re-soak it again. Load the feed tube into the end of the syringe. Hold it like this and slowly squirt the feed in. Reload it, connect it. Sometimes it looks smooth and sometimes it doesn't. Get the water to clean the feed tube. This keeps on leaking for a little while. Make sure it's dry. Line the bag up. Press it up.
So as you can see, this is a process that patients entirely do themselves. This patient takes 20 minutes to do his. I've sped it up in this video. But you can see that this is an entirely self-directed treatment, and inherently it has to be acceptable to patients in order for them to continue to do it in the lead up to their operations. And I wanted to show you some data now from a patient who distally fed with intestinal failure to show you what the immediate effect of distal feeding is on input and output. So here we have a patient who's undergone distal feeding for 8 weeks, and they've taken a meticulous diary throughout. And you can see a very interesting thing happens in the first 2.5 weeks of feeding, which is that you get a drop in the inputs and in the outputs, which is most significant in the inputs initially. And you can see this lovely curve that then responds with the inputs increasing again and the outputs staying reduced. And I've summarised this on a slide on the right, demonstrating this significant change in inputs compared to the drop in outputs, which stays lower. So this patient, his gut completely reset in the first 2.5 weeks of distal feeding, and it went into this absorbatory phase where he's able to keep his outputs down but increase his inputs going in. And clinically, he gained 1.2 kilos in the first 3 weeks of feeding, which is a fairly common side effect of distal feeding with this type of feed. His PN requirements went to 0, and he had a swift, complication-free recovery from ECF repair and complex abdominal wall reconstruction, which is no small thing. And when we look at the whole St Mark's cohort for a small case control study that a colleague, James Osmore, and I did, who you'll hear from later, you can see that this time to intestinal autonomy is not a one-off fact. It's been demonstrated in our review data that I presented earlier, but on a local level, you can also see it in the time to intestinal autonomy in months between patients who've been distally fed and not distally fed between matched groups, where both their IF etiology and their length of preoperative small bowel has been matched. So this is an intervention which in an IF community has a quite significant effect. And when you look at patients with ileostomies for other reasons, so we also looked at a cohort of patients who'd had anterior resection and formation of defunctioning ileostomy in their reversal of ileostomy, you can see that distal feeding hugely affects them too. If you distally feed these patients for an 8-week course with our prebiotic mixture, you reduce their length of stay following reversal of ileostomy by a third, you restore their bowel function a day earlier, and you reduce their cost per group by £600, which is a significant change when you consider how long patients following reversal of ileostomy stay in hospital. And I investigated the impact of distal feeding with a mechanistic study as well called Elfin, which compared the same group of patients who'd undergone TME with ileostomy with patients who'd undergone restoration of continuity for intestinal failure. We looked at 2 diets, chyme and Vital 1.5, and we investigated their gut hormonal profiles and their serum, so how these feedback loops changed. We took direct samples from the ileum, stool samples following reversal of ileostomy, and systemic samples to look at whole blood immunology. We also looked at 16S and shotgun metagenomics to try and have an idea of the microbial changes that distal feeding induced. And as you can see, this is a small study. There's 50 patients in total. We recruited 12 cancer patients, 14 intestinal failure patients, and then we matched them with a number of controls to try and get an idea of the impact both before and after resection, as well as during the feeding regime. Along these 3 time points for the IF patients and 4 time points for the cancer patients, I think we've gotten that. So starting off, comparing patients pre-cancer resection to post-cancer resection. So these are patients without a stoma but with cancer, and the middle bar of this graph is patients with stoma having had their cancer resected compared to healthy controls who are on the far right. Now you can see in these graphs that these patients are wildly different across the board. These are patients who go from high proliferative responses to a number of pathogenic bacteria, and this doesn't resolve by the time their cancer is resected. So the ileostomy has an impact on them in terms of their recovery. And I've listed all the bacteria that are affected on the right, and you can see that a couple of them are implicated in line infections. These are species that having a high proliferative response to may have a significant impact on their other post-operative complications as well. And you can see if you track, I've only shown one species here to make my point, but if you track across these time points with the far left pre-cancer resection, the yellow post-cancer resection with ileostomy, and the orange post-cancer resection and post-reversal of ileostomy, you can see that again, the impact of the ileostomy is still significant despite the patient no longer having one. Now, if we distally feed the patient, you end up with some quite interesting responses when you look at their T and their B cell memory responses in their blood. So you can see in our cancer group, if I remove any of the background data, that at week 8, the 3rd time point, these patients rapidly produce up the proliferation of their T cells, their CD4 positive cells, and that this is not reflected in these other groups. But in the IF group, they push up the populations of all 3 of these groups, and they push them up at the 2nd time point. You can see that there's this big spike in activity at 3 weeks into feeding, which reflects the case that I showed you earlier as well, and that it then dampens down at week 8 of feeding. And if you look at this heat map, you can see that even within the cancer group of patients who've had ileostomies reversed, that these responses are entirely separate. If you look at the graph on the left, you can see that patients who've had chemotherapy and radiotherapy switch on their gut homing in their T cells, in their blood, across the distal feeding regime. But after their ileostomy is reversed at time point 4, it's still switched on, and it's at its strongest. Whereas if you look at patients who haven't had chemotherapy and radiotherapy across these time points, 1, 2, and 3, they switch it on and switch it on and switch it on, and then after their ileostomy is reversed, they switch it off. So these are entirely opposite responses across these time points of patients with the same pathology who've just had a differing treatment. And this is especially stark when you compare these patients with controls who haven't been distally fed. So on the graph on the left, I have healthy control patients, patients who've had ileostomies for rectal cancer, patients who've never had an ileostomy for low colorectal cancer, patients who've been distally fed with no chemotherapy and radiotherapy, and patients who've had ileostomies and chemotherapy. And you can see that this group is still entirely separate to all the remaining other controls. And I've contrasted it with a slide on the right, which demonstrates the differences between skin homing and gut homing. So this graph, looking at skin homing, you can see this zebra-like appearance, which is where I've lined up the proliferated and the unproliferated live cells after incubation. And you can see that the proliferated cells, which are very strongly responding, look so different to their neighbours because the unproliferated cells have not expressed skin homing markers. So cells are proliferating and they're expressing markers explicitly saying, I'm going to go to the skin. And this, you can see, is also dampened down in patients who've been distally fed. These responses look quite different across these bars. When we look at patients with intestinal failure, we can see opposite responses again. If you were an intestinal failure patient who's been distally fed without IBD, you switch on your responses in a similar way to the cancer patients. Switch on gut homing, which reaches a peak at the third time point. But if you're an IF patient with IBD, you switch everything off. And as you can see, these proliferative responses are more zebra-like in the IBD group. The proliferated cells are very active, but during the feeding regime, they become less active. So they are far less inclined to home to the gut than they were at the beginning of the regime. And if we look at the impact on the microbiome, and I'm showing you results from the feces here, 6 months after closure of patients who've had reversal of ileostomy for rectal cancer, you can see that the microbial groups between the patients who've been distally fed and their control groups are very different. On the far left, you have our healthy control group, which has got the highest microbial richness. With patients who've had their ileostomies reversed, you can see that they're quite different to the patients who've never had a stoma. And the distally fed group is different again, but more similar to the patients who've never had stomas than the patients who've had ileostomies reversed, which is quite startling. And if you look at the alpha and beta diversity between these groups, and I've circled the healthy control groups, you can see that patients still haven't had a recovery for their microbiome following reversal of ileostomy. Across these groups, the cancer patients are distinctly different to the patients who've never had cancer, even after they've been fully cured of their disease. If we look at how the hormonal loops change, you can see that in patients with colorectal cancer with stomas versus colorectal cancers without stomas, that the amount of PYY they have is significantly reduced, suggesting that, as physiology would state, if the luminal contents are not hitting a cell to produce this hormone, the levels will be lower. So this is quite a nice finding in terms of endorsing how the physiology works. And if we look at the distally fed groups between these two groups, we can see that they then become equivalent. Now, GLP-1 is not significantly reduced by distal feeding, but you can see when you compare the IBD groups and the diets that the chyme diet induces a higher GLP-1 response. So physiologically, chyme is better. And this Crohn's finding of a higher GLP-1 level in patients with Crohn's is also in keeping with the literature. So during this talk, I've demonstrated that patients who are defunctioned have an abnormal immune response to the microbiome, and that distal feeding has a systemic impact. It affects circulating immune cells in the blood, and it has a benefit to anyone who has a defunctioned portion of bowel. This is an easy and achievable intervention for ileostomy reversal. Chemotherapy and radiotherapy patients have distinctive gut homing responses to distal feeding, and cancer and IF respond differently to DF. And again, patients with chemotherapy and radiotherapy respond differently to patients who haven't had it. Our clinical data from St Mark's suggests that distal feeding reduces hospital stay, reduces reliance on PN, and improves bowel function post-operatively. Thank you so much for listening to my talk.